All right, we're going to do a high-level overview of soft tissues for the anterior knee. All right. Um, if you think about if you get confused on techniques and how to best work on the soft tissues, you can reference back to the cascade of technique video for soft tissues. That applies for everywhere in the body. Okay, so I'm going to highlight soft tissues on the front of the knee and then maybe give some little kind of pearls of my bias of how I kind of think about or things that I'll see commonly for certain areas. Okay, so we have skin and superficial fascia. Okay, so you can go back, review that video, but essentially, especially on some, if you have some more chronic post-op knees that haven't been able to get their extension, haven't been able to get their flexion, often if there's a superficial fascia, skin and superficial fascia restriction, that actually can be a reason that they're not getting where they need to be. So don't skip over that. Next thing is bony contours. Okay, the main bony contour that we have here is the patella. Okay, so with the patella, you are most likely going to see a patella that is laterally tipped. All right, so where do we need to focus our attention for the patella is typically it's compressed down laterally. All right, so when I'm doing bony contours of working around this patella, I'm not just working around it like that, right? I'm actually trying to get on the medial side and I want to create a little gap of that patella and really kind of work under the edge. Like my intention is that I am trying to get under the edge of that patella as I do my bony contour. Okay, and so I could do it by using my thenar eminence here, or I could just use my fingers. And then sometimes you can just feel better with different ways. Another thing that I'll do is I will use both of my thumbs. I'll create that gapping with my index finger. I will use both of my thumbs. I will help to maintain that position with one thumb as I do my bony contour with the other thumb. And that just gives me a nice little contact there that I can use to get underneath that bony contour. Okay, so bony contours up the patella, but you do want to think all the way around. I do bias more laterally for that. Now, that's the main bony contour. You also have tibial tubercle here, right? And you just want to feel, that's where that quad attaches, right? So you want to feel bony contours around that tibial tubercle and just make sure there's no binding of the soft tissues there. And then what's between those two structures? We have the patellar ligament here, right? And so the patellar ligament, what I am most interested in with this is, does it have the ability to move laterally? Does it have the ability to move medially? And on Kelsey here, like moving medially up by the patella is fine, but moving medially down by the tibial tubercle there is not fine, okay? So I will do more of a muscle bending technique, and this would be like a tendon ligament bending technique to try and get that to free up right as it attaches into that tibial tubercle. Okay, so then my FM would be just like pressing the knee down into the foam roll, right, perfect, like that, and let it go. I could also do some flexion extension here. I could actually have her go into some knee extension, so there's options on how to get that to free up. Okay, I could also come to the patellar tendon above the patella and just kind of see, same thing, I like to see how does it bend, right? How does the whole thing glide medially? How does it glide laterally? How does it actually bend, right? And that's how I would work on that there, right? Next structure we have is the plica. Plica is on the medial surface of the knee, and if you just do a little strumming, oftentimes you'll roll over something that feels a little gristly, and there it is on her. And so that's an area that you can treat it with strumming, or you could treat it with the cascade of techniques there. But that sometimes that can cause some pain and inflammation. All right. Now if I come up onto VMO, right? We have VMO here. We have rectus here, and we have vastus lateralis here. We have intermedius kind of deep in there. So I do work on that, but it's, not as obvious one to you can't see it right from the outside. So working on VMO, right? I will typically come medially, and I want to feel how does VMO wrap around the femur, both directions, right? If there's any restriction one versus the other, oftentimes it's pulling it more laterally. I'll work on it from that direction. And again, it's kind of like a muscle play, right? But also can turn into a muscle bending technique, okay? Rectus, I typically will just move along rectus and just see how rectus moves throughout. And if I find an area that feels a little restricted or stiff, I'll do a perpendicular technique into rectus. Okay, you could also even imagine doing like a parallel technique along it, but I typically will bias a little bit more into a perpendicular technique there. Lateralis is a little harder to get a perpendicular technique on. So a lot of times with lateralis and the relationship with the IT band, I will do a very broad technique where I will just wrap my hands completely circumferentially around the thigh. I will move all of the tissue medially and see, once I get it to an infill, I'll do a pure rotational spring test, I'll do a superior medial spring test, and an inferior medial spring test. And I just want to get in the angle of that biggest restriction, and now I can have her rotate out. There. And so now I'm just doing a really general, what's the term? Really general muscle play technique on the large kind of muscle bellies, okay? And that is actually going to get vastus lateralis. It also, if I come a little bit more medial and then do the exact same thing and sink in, then I can get the intermedius also as well there, okay? Just with a little bit of a difference of bias and how the depth to which I'm sinking. I love doing that. So oftentimes we get, all of our soft tissues get pulled laterally here. So again, just a bias doesn't mean that you're not going to come in and do the opposite of that as well. Okay, now IT band. I will do kind of a similar thing for IT band, but I will actually try to take IT band away from quad or away from lateralis, okay? So for IT band, it's coming down the outside here. Oftentimes it gets more dysfunctional as you work your way down towards the knee, and especially like this last kind of third of the femur. I will do a technique where I am coming on the superior border of IT band, and I will actually see, does it have the ability to spring down towards the table, okay? And then I'll just kind of go along where I imagine IT band and just feel as I go along, like it's a little tight right there. And that's actually the worst part, right there at the beginning of that last third. And it's probably tender as well in this moment. I don't care. And so I will sink in on that with a perpendicular technique there, and then I'll have her try to take her leg in. So rotate in, and I'll just maintain that barrier there. Good, and let it go, okay? And so I'm not trying to stretch IT band at all. I'm trying to get IT band to move on the tissues that are deep to it, okay? So the ways that you can do that is work perpendicularly along it to kind of separate those tissues. The other way would be potentially to do, you could do a little decompressive work with cupping or plunger to get that to decompress, or you can roll it. The intention of rolling, you could do, it could be like some desensitization, like neuro type thought process, or the thought process with the actual compression and rolling is that you can get some of those, like the surface of IT band to quad to kind of free up a little bit as well. And then that can help with the general mobility throughout that area, okay? So we've worked on a bunch of stuff. Other things that we have in the anterior portion of the knee, right? We have Gerrald's tubercle out here where IT band attaches, and then we have pes anserine area here. What attaches on pes anserine?
Sergeant.
What'd you say?
Sergeant.
sartorius, gracilis.
Semitendinosus.
See, this is great. I'm glad we have help. I don't think about things as much that way. I shouldn't say that in this video, but I just want to see, I know that that's an area where multiple things kind of come together. Any area where multiple things come together in the body, I want to see, is there a mechanical restriction there? If it is, then I want to work on where all those tendons kind of attach, and that's one of those areas, okay? So this is anterior soft tissues of the knee. High level overview, kind of told you how I'd think about doing all of it, but hopefully that's helpful as you go through and figure out what you want to work on the front of the knee.